but I'm going to be talking more about the application of sex differences in finding treatment courses for complex neuroinflammatory illnesses. So specifically, I'm going to be talking about Gulf War illness and some of the work we've been doing here at the Institute for Neuroimmune Medicine. So for those of you that don't know, Gulf War illness is a complex chronic neuroinflammatory illness that's resulting from the 1990-1991 Gulf War conflict. About a third of the troops returning from that conflict came back with unexplained symptoms. So chronic fatigue, musculoskeletal pain, gastrointestinal pain, brain fog, joint pain, and so forth. The actual etiology and what the cause of that is not quite known. What is believed is that it's due to a low-grade exposure to a nerve toxic agent, particularly sarin, after the demolition of a munitions plant in the region, and that gas wafted across the entire troops. And due to the stress of the wartime environment and exposure to that agent, it resulted in these symptoms. Now, they've invested about $1 billion into Gulf War illness health since the inception of the war, the end of the war. But no treatment has been found for this illness, and we're still trying to understand what it is that caused this illness. So we need to make progress on this. But one of the main problems with this illness is the vast heterogeneity in the presentation. So you can imagine that if someone comes back and they meet certain criteria for the illness, such as brain fog, cognitive problems, and gastrointestinal issues, and then you have another person that comes back and they have the brain fog, but they have musculoskeletal pain and fatigue, that those two people will probably have a different underlying biology that's giving rise to that presentation. And because of that, when you're trying to compare these two individuals, you're going to get vastly different results, especially if you're using the same sort of assays over and over and over again. So one of the things that we've decided to do is to better characterize these illnesses is to subtype them. So look for specific groups of these people with these illnesses and see if those more similar groups have better symptom presentation or better underlying biology or better described underlying biology that gives rise to these symptoms. So the first avenue that we looked at is post-traumatic stress disorder. So considering that we're dealing with a military population, these individuals coming back are likely to have either been exposed to traumatic events or experienced traumatic events, and that these can Okay, so I need to see the screen though. So they're going to be likely to have experienced a traumatic event, which can give rise to post-traumatic stress. Now, post-traumatic stress disorder is characterized by distressing memories, so recurrent thoughts about the traumatic event, avoidance of things that remind you of the event, hyperarousal, always being vigilant of things that may be reminiscent of the event, causing you to avoid that. Additionally, there are underlying biological differences in individuals that have post-traumatic stress disorder versus those that don't. So they tend to have higher cortisol levels as well as different responses in immunity. It's estimated that about 12% of the vets returning from the Gulf War have PTSD, but that's all of the vets that are coming back. Now, if you look at the individuals that have Gulf War illness, that increases up to about 35%. So now the post-traumatic stress disorder is treated mainly by cognitive behavioral therapy and some anti-anxiety medications. But if we try and understand what the underlying biology of that is and the changes in immunity, we can look at that in comparison to the underlying immune dysfunction that we can see in Gulf War illness and try and tease apart what it is that belongs to Gulf War illness, what it is that belongs to post-traumatic stress disorder, and what it is when you have both of these conditions together, when you have a comorbid condition. The second way of subtyping is based on sex. As well, we've heard from Dr. Strat that we have this sexual dimorphic difference in human beings owing to the difference in the endocrine systems of individuals. Now, going back to the illness, because it's a multi-symptom illness, multi-symptom illness is all over the body. We're talking about stuff that's going on in the brain, stuff that's going on in the gastrointestinal system, stuff that's going on with your endocrine system, with your immune system, with joints and so forth. Is if you're looking at multiple symptoms, you're looking at multiple systems within the body. Now, classic textbooks in medicine tend to break these systems up for ease of understanding them. So you may get a chapter on the brain and the nervous system, a chapter on immunity, a chapter on cardiovascular health. But these things really are not separate. They're all interconnected with one another, and there's a vast amount of crosstalk across these systems. Primarily, what we look at is the neuroendocrine immune system. So the way that the brain talks to your endocrine system through things like your fight or flight axis, the HPA axis, or the sex axis, your HPG axis, and how those things interact with your immune system. So you have your peripheral immune system, which is throughout the body, and then you have a neuroinflammatory or neuroimmune system within your brain, and those are separated by the blood-brain barrier. But they can communicate back and forth across that blood-brain barrier and with the endocrine system. So you have this tightly knit system going back and forth that you have to look at everything. Now, if you have a different endocrine system, so you have men versus women, the way that those endocrine systems interact with the immune system is going to be different. And so if you're affecting the immune system by some agent such as sarin, or through something like a traumatic event and ramping up your cortisol levels and changing your immunity in response to that traumatic event, it's going to be different in men versus women. So we need to look at these things, these subgroups separately to try and tease apart not only what the effect of post-traumatic stress disorder is on Gulf War illness, but also what the effect of sex differences is on Gulf War illness. So in this study, this is a dual study that I have that's funded by the Department of Defense, the Gulf War Illness Research Program through the Congressionally Directed Medical Research Program. They awarded me 2 awards, one to look at men, one to look at women, in order to tease apart the effect of post-traumatic stress disorder on Gulf War illness. We hypothesized that post-traumatic stress disorder is going to alter the way that immunity is affected within Gulf War illness. And furthermore, we hypothesized that due to sex differences, that you're going to get a different presentation between men and women across these immune measures. So what we did is at the Institute for Neuroimmune Medicine, we have an ongoing Gulf War illness research program where we've received multiple awards over the years. And through those multiple awards, we've taken many, many assays and many, many measures of both men and women vets with Gulf War illness and without, and we've stockpiled them so that we have vast amounts of data that we've now compiled to do a secondary analysis on. So we've taken that data, grouped it together, gone through it, pulled out individuals that meet criteria for post-traumatic stress disorder, as well as those individuals that don't meet criteria for post-traumatic stress disorder, and then separated them by gender, and then compared their immune profiles and their psychometric profiles. So this is our cohort. It's primarily been recruited through the Climas Clinic down at the Miami Veterans Affairs Hospital. And this is kind of the breakdown. For the most part, the majority of the people that we see through the clinic are men. The military is primarily male dominated, with a fraction of the returning vets coming back having this meeting criteria for Gulf War illness. It's similar for women, but because they're initially a smaller cohort of women going over to war, it's a smaller cohort coming back, so they're much harder to find within this study. It's broken down. Most of the trauma for men has been reported as a military trauma, whereas for women, it's tended not to be reported. In further, subsequent to this study, we found that it tends to be a high degree of sexual trauma outside and within the military. The first thing that we did, we wanted to see what is the effect of trauma on symptom presentation. So how does trauma gradate your ability to report on feelings of fatigue, your overall general health, your cognitive function, your mental fatigue, the role that you play, that physicality plays in your daily life, or your emotionality plays in daily life, and so forth. So we use these measures called the RAND-SF short form 36 health assay or health outcomes measures, or the multidimensional fatigue inventory, the MFI. And so what we found overall is, after accounting for age and BMI in men, we found a gross difference between our cohort, our healthy controls, and the ill people with Gulf War illness in the male group. Those with Gulf War illness tended to be heavier. They tended to be and a little bit older than the control group. So we accounted for that in a model, and then continue to regress the model based on Gulf War illness health status, and then upon the Davidson Trauma Score, which is a 17-point measurement scale to assess the degree a traumatic event has affected your life. usually with a value of Davidson Trauma Score total of 70 or above in the military. That's taken to mean a high probability of having PTSD. So what we found overall is that the prime predictor for the increase in these measures is the Gulf War illness health status. So primarily, what is driving the certification of these problems in general health and energy and fatigue and so forth is the fact that you have Gulf War illness. But that if you also have PTSD or meet the criteria for PTSD, that this further enhances the degree to which you're reporting these negative health outcomes. For women, we found the same. We did not find the same difference in the age and BMI within the groups, so we didn't account for that in the model. But again, looking at the Gulf War illness status, primarily the negative reporting of these health outcomes is driven by your Gulf War illness health status, and then adding on top of that your traumatic exposure, your traumatic event that further enhances the problems within your health reporting. This is a little bit easier to understand. If we look at comparison just of two groups, or so now subtyping, moving from just a scaled continuous comparison of trauma on Gulf War illness health status, if we make a cut point, if we take that Davidson Trauma Score and say anyone that has a value of 70 and above, say that they are PTSD probable, and then call that a group of Gulf War illness high or Gulf War illness PTSD plus, and then make a separate group that if you have a Davidson Trauma Score of 70 or below, and call that a low trauma group or a PTSD negative group, and then compare these health measures. For the most part, you can see across the board that all the measures in the Gulf War illness high group or the PTSD positive group are greater than that for the low trauma group. It reaches levels of statistical significance in things like social functioning, the role that your emotions play in your daily life, your emotional well-being, your general fatigue, and your mental fatigue overall in men. Okay, so primarily this is not something that is unexpected. These are things that you would associate with something along the lines of post-traumatic stress disorder, not going out as much, having higher degree of emotionality, especially when you're exposed to something that's a triggering event and so forth. We find a similar profile for women, in addition to the fact that they're reporting increased levels of fatigue along with increased levels of trauma. Now, if we move on to the actual biological measures, for men, what we find is that across the board, there's several significant differences, and these are different for the low trauma group versus the high trauma group. So these are presentations of immune cytokines, so immune signaling molecules, as well as counts of immune cells within the blood. And it's all normalized to healthy controls. So healthy controls would be at a value of 1 across here. So for pro-inflammatory cytokine IL-1B, we can see that for the low trauma group, you have that pro-inflammatory cytokine being much lower than it is in the healthy control group. Whereas for something like IL-8, we have a large degree being increased in the high trauma group. And so we see this different response for several of these measures between the low trauma group and the high trauma group. However, for some measures such as CD2 plus and this CD3 minus CD56 plus measure, these are immune cells that are associated with either T cell or natural killer cells. And these are the same for both of the illness groups. Now, it's been purported by the Climas Clinic and the group of Dr. Marianne Fletcher for a period of time now that in Gulf War illness as well as in chronic fatigue syndrome, that the prime driver of these illnesses is dysfunctional NK cell activity. And so we do see that here. However, for some of the other measures of NK cell activity like CD3 minus 16 plus or 11A plus, we only see this in one of the illness groups. Additionally, a signaling molecule that is associated with NK cell function, IL-15, is only seen in the low trauma group. So we're seeing some things that are attributed to both high and low trauma groups, and some things that are attributed only to one group or the other. And this is what we're further looking into as a subtyping mechanism for high versus low trauma in males. Now, if we look over at females, again, we get differences, but there are some similarities between males and females. So your differences in IL-15 are the same, as well as for some of the measures for NK and cell activity, such as the CD3 minus and CD2 plus measures. But again, now we have something completely different that we do not see in men, differences in IL-17 signaling and TNF beta signaling. And so what this is indicative of is something that's different in the underlying immune function that's going on in the system. Now, I haven't discussed it here, but we have done modeling of these groups. We have models of the combined neuroendocrine immune system for both men and women. And if you look at the difference in the way that these regulatory systems respond to a stressor, you can find that certain behaviors that are available to all behaviors that are available to men are available to women. Okay, so that was the first finding in our models. The other thing is that beyond the normal behavior that is attributed to men and women have additional responses that are not available to men due to the way that the endocrine system can regulate immunity. So because of the biphasic nature of the way that estrogen and progesterone can affect the hypothalamus pituitary gonadal axis, in some ways it can resemble what is going on in the male system, but because the polarity of that can change during the ovulatory cycle, then you're going to get changes in the way that the neuroendocrine immune system changes over time, and that is not available to the male system. So we think that this is what we're picking up here in some of the measures, and we're further going on and trying to use this now with the modeling procedures in order to predict not only PTSD, high trauma versus low trauma specific treatment courses, but men versus women specific treatment courses. So overall, the comorbid conditions of Gulf War illness and post-traumatic stress disorder, post-traumatic stress disorder tends to worsen all symptom outcomes. These are detrimental effects, but primarily seen in things that you would attribute to post-traumatic stress disorder: social, emotional, mental performance, and in the case of women, you also get that with your energy or vitality levels. Addressing just the symptoms of PTSD in these groups, in both men and women, may alleviate a lot of these problems. So not only if you have Gulf War illness, whether you're a man or a woman, but you also meet criteria for PTSD, it's vital in order to alleviate your symptoms of Gulf War illness that you address the PTSD, because it's just going to exacerbate a lot of those symptoms that you're already feeling. The underlying biology within both men and women points to a commonality across Gulf War illness, regardless of PTSD status, in the natural killer cell activity. In the men, we also see changes in IL-8 versus IL-1B, depending on your PTSD status. And in women, we see that in IL-17 versus TNF beta. So these are our potential biomarkers for these subgroups that we're further looking into. Overall, subtyping Gulf War illness with this method of either traumatic stress or sex seems to be a viable option for enhancing signal that we may be able to use as a reliable biomarker for these conditions, and therefore further study is warranted. I'd like to thank the funding provided by the CDMRP